My name is David Mayo, and I'll be covering moral distress in critical care nursing. Moral distress occurs when a nurse cannot follow through with moral actions and compromises professional integrity. Ethical conflict is an antecedent to moral distress and occurs commonly in nursing practice. Nurses describe moral distress as a painful experience of frustration, anger, sadness, helplessness, and suffering a whenever they feel like that their patient isn't receiving the adequate care that they need. I'll be covering the 3 points: factors that contribute to moral distress, the impact of moral distress on nurses, and the impact of moral distress on patients. Some contributing factors, according to McAndrew, Lesk, and Schroeder in 2016, were nurse-physician relationships, nursing autonomy, and their organizational challenges within the organization that they work with. In regards to nurse-physician relationship, a contributing factor to moral distress is whenever the nurse feels like a physician is providing incompetent care for their patient. It's reported by nurses to be one of the most frequent and one of the most intense causes of moral distress whenever they feel like that their patient isn't getting what they need because the physician isn't ordering a scan or a lab or ordering medication or providing a treatment for that patient. Causes distress in the nurse. Ineffective nurse-physician communication. Nurses were more likely to report lack of physician communication as a cause of medication errors, which can increase the moral distress. And barriers to addressing ethical concerns. There's a barrier with physicians providing incompetent care, according to these nurses, because of an occurrence of unprofessional behavior in the physicians that they work with. Another contributing factor is nursing autonomy, the inability to be an advocate for the patient and lack of involvement regarding decision making. Nurses have expressed being devalued and their contributions to care to be ignored. Nurses spend some days and weeks with patients and their families, caring for them, and sometimes they feel like they do all this only to be dismissed by physicians and have their opinions treated as something of little value, to be not listened to, as instead of being listened to as an integral part of the healthcare team. Many experience distress over, even if they speak up, they feel like they're not listened to. And organizational challenges. When a hospital exhibits financial constraints, can lead to distress on nurses due to the fact that their patients might not be receiving the diagnostic exam that they need because of money issues with the hospital, or they might not be receiving the medication that they need because it's an expensive medication. And this is especially seen with patients who have no insurance and ultimately will not be able to pay their bills. Their treatment is seen as substandard because of their inability to pay and their ability to make the hospital money. Some nurses even said that the hospital's budget and the hospital's profit was seen as a priority over their patients' lives, over human lives. And lack of staff, with the same thing that goes back to costs and budget cuts. Whenever a nurse's patient load is higher, they feel like their quality of care is worse than it should be, because the hospitals aren't willing to pay for adequate staffing. So a higher nurse to patient ratio can lead to distress for the nurse because they feel like they're not giving their patient what they need. And the impact of moral distress on nurses, I've already kind of touched on it here and there. But nurses reported the moral distress as a cause of burnout. If time and time again they feel like what they're not doing for the patient is enough, it can cause emotional exhaustion and burnout for the nurse. Feelings of helplessness and feeling that they're compromising their own nursing values, their own values in general, and they're compromising the quality of care given to their patients because they feel like they're not doing enough for the patients time and time again. And increased med errors, which again leads to burnout, emotional exhaustion, if unclear orders or communication, lack of communication or communication errors leads to increased med errors. The nurse may blame themselves really, and increase emotional exhaustion, increase burnout. And the impact of moral distress on patients, prolonged suffering for the patient, especially in the critical care settings where decisions are being made to withdraw care, to keep treating aggressively. It can lead to prolonged undignified dying, like prolonging withdrawing of care for the patient, a poor quality of life, delayed or prolonged treatment, and false hope. What's seen a lot of times whenever there's moral distress in the nurse because they're not being listened to, it's lack of communications between doctors and nurses to doctors as well. And it ultimately leads to lack of communication to the patient's family. And a lot of times it can be given false hope because one physician may say one thing and another physician may say another thing, and they aren't communicating. And the nurse, as the mediator, isn't able to put their input in for the patient's care. And some false hope may be given to patients and their family members as well. But in my own practice, we can use this to be more aware of precipitating factors of moral distress. If I see that I'm beginning to not be listened to by a physician when my gut feeling or when I feel like my patient needs something, to be aware of it so you can act on it fast. Because if you don't act on it fast, the longer this goes on, the harder it can be on the nurse and the harder it can be on the patient and the family member. And if I feel like that there's something that's not being met with my patient, I can inform nursing managers or, quote, go up the ladder to see what I can do for my patient as the patient advocate. Talk to my nursing managers to see if they can mediate something, or if I can go up and try to get an order for an exam or medication that I feel like very strongly that my patient needs that they aren't getting. And to be mindful of potential consequences if I don't do my part in advocating for my patient. If I feel like that the oncoming nurse may be able to take care of it, or that I won't be listened to anyways, if I keep in mind that the quality of patient care may suffer, or that the patient may suffer because I'm not doing my part, then it'll encourage me and to do my part and to just advocate for the patient. My references. And as a critical care nurse, starting out just for a few months, I found this very informational. and just to be more mindful of that as a nurse advocate, to do what I think is best for my patients and to help my patients recover and just do the best that I can. Thank you.